Good evening, everyone. Thanks for joining us tonight. The webinar Living with Lung Cancer, organized for the Florida Society of Clinical Oncology, FLASCO. FLASCO is a member-supported state society that focuses supporting and representing the oncology workforce of Florida. We call ourselves the voice of oncology in Florida because we want to be involved in anything related with oncology that can move forward the fight against cancer. And it's particularly important for us the fact that patient advocacy and help our patients deal with this very dangerous disease is important for us. That's why we are very, very always happy to have supporters, collaborators, and other people that help us develop advocacy programs like the one we're going to do tonight. And so that's why we're very grateful also that we have several members of the society tonight as speakers and faculty, and that's very important for us. My name is Luis Raez. I am the medical director of Memorial Cancer Institute. I am also the chief scientific officer. I am the president of the Florida Society of Clinical Oncology now, and I am going to be the moderator tonight for the discussion. Our panel of oncology experts and I will discuss lung cancer and the treatment options, as well as other focus areas that we are going to share with us related with advocacy and including, for example, support for caregivers and other issues that are very important for you. Before we begin the presentations, I want to give thanks to our sponsors. All of these educational events, advocacy events that we do, because we are a voluntary society, a society of volunteers, comes from the industry. We're very grateful for the industry for the support. We have Genentech, a member of the Roche Group, supporting tonight. This webinar is being recorded tonight. So if you want to share with a friend or somebody else that want to attend but was not able to come tonight, we are going to be able to share with you in our website later today. Note that your lines will be muted during the presentation, but at the end of the presentation, we're going to do a Q&A, question and answer, and we encourage you to submit your questions. I know sometimes it's difficult to talk in these virtual worlds, but that's why you have the opportunity to submit your questions by the on-screen question box in your GoToWebinar panel. If you see in the right, in my case, it's in the right side, the GoToWebinar panel. So you can submit your questions anytime during the presentation. At the end of the presentations, we will try to address as many questions as possible, because this program tonight is about you, the patients and the caregivers. That's what we're here for tonight. We're here for you. I really would love to go back to normal life and do this in person as we used to do. But I promise you, hopefully, the next one that we do this will be in person, as we usually do. I am honored to introduce our accomplished group of panelists for the webinar tonight. I want to briefly introduce them now, but in the invitation you can see the bios, and they have been emailed to you. Our first panelist is going to be Dr. Edgardo Santos. He's a very good friend of us. He's a leader in FLASCO. He's an oncologist of Florida Precision Oncology. It's a division of the 21st Century Oncology. He works here in Ventura and Boca Raton. He has lectured in many topics related to lung cancer and head and neck cancer, and he's our current secretary for FLASCO. Our next panelist is Dr. Estela Mari Rodriguez. She's the Associate Director of Community Outreach, a member of the Lung Cancer Site Disease Group of Sylvester Comprehensive Cancer Centers of University of Miami. She's well known in our lung cancer community. She has been working many years before as the lung cancer expert at Mount Sinai Hospital, and she has given numerous lectures on issues related with lung cancer and healthcare disparities. It's also a pleasure to have with us tonight Mrs. Lindsay Niebrink. She is an oncology social worker at Cleveland Clinic, Florida, and she's always very supportive in all of these advocacy events, because she, other than her specialty that is solid tumors, she has a lot of understanding how to provide emotional support, resources, and referrals to the patients and the caregivers. We want to tell the caregivers tonight, we don't forget about you. I know that the patient is the center of our attention all the time, but in my 20 years of oncologist, I have seen how much the caregivers suffer in all of this process. And of course, you know, you're in the, a lot of times we believe that you're in the second row because the patient has to be the center of attention, but we want to let you know that we also care a lot of our caregivers and we're trying to help you. And finally, our last panelist is Dr. Michael Diaz. He serves in the executive board of the Florida Cancer Specialists and Research Institute, and he has assistant managing physician and vice president of Florida Cancer Specialists. He's also our director of advocacy for Flasco, and he has recently been the president of the Community Oncology Alliance nationwide. Thanks for your panelists for joining tonight, for volunteering to help us tonight in this important program. We are going to begin the presentation. I'm going to say 2 words only about how is the situation of lung cancer now, and then we'll proceed for the presentations. Can you show my slides, please? Next one, please. Okay, so one important thing, I think all the patients and family are, and I guess we are familiar, is that the lung cancer is not one disease. We had very poor success with lung cancer before because we give chemo to everybody and we didn't have an idea who is going to do well, who is not going to do well. I have patients that are being cured with chemo. That's not very common. It's uncommon to have cured with chemo. And there are patients that didn't survive even a year on the same chemo. Now we know, and you can see in this pie chart, that the lung cancer is not one type of cancer. Thanks to this genetic analysis, we have discovered that lung cancer is a family of many different diseases originated by different genetic aberrations, genetic alterations. And that is why now we are doing the job to target these alterations one by one. And we know that they have different behaviors, different responses, and we even have different treatments. The next one. The next slide, please. That's why we do now precision medicine, you know. If we have a patient group, not all the patients are the same, not all have the same disease. Now, thanks to this genetic analysis, molecular analysis, we classify the patients. And then each patient receives a specific treatment. For example, some of you may suffer from EGFR tumors. They get EGFR treatment. Some of you may suffer from a genetic alteration called RET, R-E-T. You get a specific pill for that genetic alteration. Some of you don't have the genetic alterations, but you have a predisposition to do well with immunotherapy. So we start your treatment with immunotherapy. The next one. And the other important revolution for us lately is the liquid biopsies. We started 6-7 years ago doing all of these genetic and molecular classifications of these cancer tumors in the tissue. But it was so difficult because, as you know, we get a very small biopsy from your lungs, and we spend most of this biopsy classifying what type of cancer it is, most of the time lung, but sometimes can be other cancers. So sometimes there is not enough tissue for the molecular analysis. So now we are able to discover this, to isolate lung cancer from the blood, so we can run this molecular analysis and we can classify the lung cancer better, so we can give you a specific treatment, a personalized medicine, as we mentioned before. Next one. And well, this slide is a little bit moved, but I only want to tell you that the 2020 maybe was a terrible year for all the humankind, you know, but it was also a good year for lung cancer. Despite the pandemic, I am very proud to say that our worldwide lung cancer community keep working forward. So we were having able to approve several drugs for lung cancer. For example, the first 2 drugs, selpercatinib and pralsetinib, are drugs for the genetic aberration called RET. Some of the lung cancers have this RET genetic aberration, and these 2 agents, these are pills that are non-toxic. You know, I have personally treated 11 patients with this genetic aberration. They do very well, and they respond very well, and they have outstanding quality of life. And we were lucky this year, in the middle of the pandemic, to have selpercatinib, pralsetinib approved. Then we also have capmatinib approved. This was the first drug approved for a genetic aberration called MET exon 14 that some patients carry. Lurbinectedin, the next drug, is very important because lurbinectedin and durvalumab are drugs approved for small cell. A small cell for 20 years didn't have a single drug approved. Since I finished, I remember, medical school until this year, there was not a single drug approved for a small cell. except one in 2001 that was topotecan, that is a very, very okay drug because it's not very good. So that's why it's amazing this year that we have 2 drugs approved for small cell, lurbinectedin and durvalumab. And next one, please. And this is what makes the difference. When we used to give empirical chemotherapy in 2001, we didn't know what type of cancer you have. I know that you have lung cancer, but not what type. The survival was 1 year for stage 4, that the majority of patients have stage 4. And you can see, for example, this is a publication of this year. If you have the genetic aberration ALK, if your type of cancer is ALK, the survival for a stage 4 patient now is 7 years. 7 years, 81, 82 months, 7 years. So that's why we have to fight for the patient with lung cancer. Lung cancer is not like, oh, you got lung cancer, there's nothing to do for you, I'll send you to hospital. There is a lot of hope. And that's why I want to give a positive message now. So that's why it's so important to find these genetic aberrations, because we give you a specific therapy for the genetic aberration, and we don't give you empirical therapy that don't give you a good survival. Next one. And this is another example. Okay, I know a lot of patients don't have, only 30% of Americans have these genetic aberrations, but we're working hard in the first pie chart that I show you to discover more drugs for the others, that there are no pills approved yet. However, all of the patients are candidates for immunotherapy. And this is an example how we're also changing history with immunotherapy. I mentioned before that in 2001, only with chemo, the median survival was only a year. And you can see in this table that was presented recently in ESMO last September in the Congress, that 30% of the patients that have this marker called PD-L1 positive, more than 50%, 30% are alive 5 years later. 5 years later, 30% are alive with a very good quality of life. Okay, and I think that's the last one. Next. Yes, so that's why I want to give a message of hope. You know, lung cancer is a very difficult tumor, it's a lethal tumor, but thanks to the personalized medicine, we're making a lot of progress. And I just show you the progress for many people, the worst year of their lives, the year of the pandemic. But even in that year, we have made a lot of progress, a lot of hope, and there is many things that we can do for our lung cancer patients. So that's why I'm going to stop here, because I'm only the moderator. I don't want to give a lecture. So I'm going to turn to off my cam, and I'm going to introduce Dr. Edgardo Santos, who's going to turn his cam on, and he's going to do a brief review for the diagnosis of stage. Dr. Santos, please.
Hi, Dr. Raez. Thank you for the kind introduction. Thank you for everyone that listen us at home. As Dr. Raez mentioned, I am a medical oncologist focused in lung cancer. My practice at this moment is located in Aventura, here in South Florida, and hopefully in the future also in Boca Raton. I am the medical director of research services for Florida Precision Oncology, a division of Genesis Care, and I am a clinical affiliate associate professor of medicine at Florida Atlantic University and the actual secretary for FLASCO. So thank you for the sponsor, Genentech, for having or giving us this opportunity to discuss this important topic. As Dr. Raez mentioned, a lot of things have changed in lung cancer. So they give me this topic: overview diagnosis of lung cancer, staging and treatment of early stage. Next one. So I want to discuss 3 topics. The first one is to do with diagnosis of the early stage. We need to be pending on the symptoms when we suspect that something is wrong with our lungs. The other 2 topics are development that happened in 2020, which I believe are major steps forward in the treatment of lung cancer at an early stage. especially on those patients that go to surgery and what happened after surgery. One is a recurrent risk stratification using the tumor that is taken out by the surgeon. We analyze this with a molecular test. And the other one is analyzing the presence of epidermal growth factor receptor, known as EGFR, in patients that were also resected. Those are two major steps forward in the treatment of lung cancer from my point of view that happened in 2020. Next slide. So when the patient start to get symptoms, or the human being start to get symptoms because we don't know what's wrong with the patient, they need to be pending of certain kind of things, such as, for example, a persistent cough, if the patient develop any kind of sputum with tinged blood, if the patient start to have like general malaise, perhaps some weight loss, some hoarseness, those kind of things that are new, acute, the patient needs to pay attention on that, especially if the patient is a former smoker, as you can see in the slide, or a current smoker. Okay, it's very important. Now, we also need to recognize, and this is a stigma in lung cancer, that 20% of the lung cancer diagnoses are coming from human beings that they never smoke in their life, okay? Never a smoker, okay? So as I told my patient, the first risk to have lung cancer is to have our own lungs, okay? So the mentality that we always have to blame the smoking, we need to keep away a little bit from that. Yeah, it's true, cigarette is one of the major factors to develop lung cancer and also many other malignancy, but we also need to understand that if you don't smoke, you still may have this bad disease. So the question here is the following. In patients that are at risk, okay, as you can see here, people that are smoking, and in that group of age, 55 to 74, one of the major steps that we have made in the United States and in other latitudes is to screen for lung cancer. So who qualify for this? Well, those are patients that are between 55 to 74 years old in fairly good health, okay? Because the idea is to recognize the lung cancer quickly and send the patient for surgery. Those patients are actually smoking or they quit smoking 15 years ago. Now, they also have to have something that we call 30-pack-year smoking history. What is that? Okay, it's basically a patient that smoke a pack a day for 30 years. How many packs a day do you smoke and for how many years? So this means that this human being with 30-pack-year smoking history smoke 1 pack daily for 30 years, or 2 packs daily for 15 years, you do the math, or 3 packs a day for 10 years. Okay, so you have 35-year smoking history or more, you still qualify for this, and also the patient must receive counseling for quit smoking, and also there is no contraindication for what is today from people like Dr. Reyes, Dr. Rodriguez, myself, and thoracic oncology, and a standard of care, the low-dose CT scan. Now, the low-dose CT scan was came in the United States a few years ago when the National Lung Cancer Screening Trial showed 20% reduction in mortality by using low-dose CT scan in this population. And then in 2019, at the ISLC, the International Association for the Study of Lung Cancer, in the World Congress in Barcelona, the Nelson study from Europe also found similar results to the study developed in the United States. And in the Nelson study, they found a significant reduction of mortality. To be more specific, 26% reduction in mortality in death in men, and in 33% reduction in mortality for female patients that were smoking. That study started in 2000 and ended up accrual in 2015. Those patients were followed for more than 10 years, and the study was striking positive. So if you see this screen and you are in this category, you should ask your primary care physician, you should ask your pulmonology, please, can I enter into a lung cancer screening program? Next slide. Now, if by any chance the patient is found to have lung cancer, okay, then the most important thing that we need to move is, number one, a biopsy, proving that the patient has a malignant disease, and then the staging, because the staging is what is going to dictate the therapy. What is the next approach? So what we do is usually, once we do a X-ray or a CAT scan and we found a lesion, the next step is to do a staging and at the same time order a biopsy. And this biopsy can be done by CT guided biopsy using a computer tomography, or it can be done by a bronchoscopy, which is a scope that goes through the airway, and we call that bronchoscopy. And then in the tip of the bronchoscope, there is an ultrasound that can look where the lesion is, or sometimes we use something that we call the navigation system, also using a bronchoscope and other technology to reach the lesion and do a biopsy. Okay, so we have a diagnosis. Okay, the patient have non-small cell lung cancer, which are different types. I don't want to enter into that because we don't have time, but the patient has non-small cell lung cancer. That could be an adenocarcinoma, a squamous cell carcinoma, large cell, and others. Then we need to stage the patient. What is that? Well, the CT scan will tell us the T, which is the tumor size, as well as if there are some lymph nodes in the chest, behind the chest bone, behind the sternum, and that is what we call the mediastinum. So then we know the patient has either N0, N1, N2, N3, what you see there. We also do a PET CT scan, which is a nuclear medicine study that will check the body from the base of the skull up to the thigh, or maybe it could be the whole body, and see if the disease has spread. And then if the disease seems to be localized in the lung, then the patient has an early stage, which is my topic, and then the next step will be if this is a surgical candidate or not, and then we move on. If the patient is a surgical candidate, we also check a MRI of the brain, a magnetic resonance imaging, MRI, just to be sure that there is no a lesion in the brain. In the right side of the screen, you see the survival of the patient after surgery, and you can see that this disease, lung cancer, even an early stage, is at 5 years, we still lost a significant amount of patients. But we are making a lot of progress to correct this and improve those numbers. Next slide. So in early stage, if the patient has a localized disease, a small tumor, no lymphadenopathy, we're going to put a very clean case, and the PET CT scan was negative for spread disease, then the patient goes to surgery if he's a candidate for surgery. And this could be a lobectomy, which the right lung has 3 lobes, the left lung has 2 lobes. So we remove that lobe where the tumor is, or we do a wedge resection, which is a piece of that lobe where the tumor is. If the patient is not a candidate for surgery because the patient has so many comorbid conditions, COPD, diabetes, and many others, or very bad heart disease, and the surgeon said this patient is a high risk to go for surgery, then we offer a radiation therapy in something that we call a stereotactic body radiotherapy, SBRT. And as you see there, this is for non-surgical candidate, stage 1, and selected stage 2 with no lymph node. Now, We move on. Patient go for surgery. What happened after surgery? Well, after surgery, as Dr. Reyes mentioned, the cornerstone for many decades has been chemotherapy. Now, the benefit from chemotherapy has been an absolute benefit of 5%, which you may say is small, but is also comparable with other adjuvant therapy that we see, for example, for colorectal cancer. But the incidence of lung cancer is so high that that 5% of absolute benefit represent a lot of life that we can save by giving adjuvant chemotherapy after surgery. Not every patient after surgery needs chemotherapy, but is one possibility. The other possibility, which is new, which was approved on December 18, and I have a picture for you at the end of my presentation. It was approved on December 18, 2020, not even a month ago, which is we also start to test after surgery if the patient have an EGFR mutation. And if it does, patient will be treated. Or the patient can go into clinical trial in which we are at this moment studying immunotherapy and other targeted agents. And also, some patients may need radiotherapy after surgery because when the patient goes for surgery, after surgery, the patient may end up with a higher stage, okay? And then if there is a presence of lymph node in certain part of the mediastinum, the patient will need radiotherapy. And then when we finish the adjuvant therapy after surgery, patient will go on surveillance with us, the medical oncologist, for up to 5 years or more, depending on the case. Next slide. Now, we are going to bring molecular medicine to early stage non-small cell lung cancer. Dr. Reyes mentioned personalized medicine. Everything right now in oncology should be personalized, individualized, because we know that every patient is different from each other, every tumor is different from each other, and we need to emphasize that, and specifically lung cancer, because every single lung cancer is totally different, molecular speaking, and if we identify where is the mutation that is causing the problem, we may have a therapy for that, or we may investigate that as we are doing in several clinical trials right now. So in the early stage, for me, one of the most important things that we have done is to create a recurrent risk stratification for early stage non-small cell lung cancer. What is that? Well, this is basically a test that is done from the tumor that was taken out by the surgeon. We take the tumor and we analyze by applying gene expression of 14 genes, and the score is coming as a high, intermediate, and low risk. If it's high and intermediate, we offer those patients chemotherapy, and if it's low risk, we don't offer patient chemotherapy, but that is for a stage 1 to stage 2A. Those are very early stage. Because of lack of time, I cannot go deep on this, but I will, next slide, but I will show the following slide coming from Dr. Woodard, and it was presented in October in our Lung Cancer Congress in Chicago, in which 250 patients were analyzed, but we are going to focus only on the 177 patients that they had stage 1A. You cannot have a tumor smaller than stage 1A. And when we apply this test, okay, and this is after surgery, we still can see in the right side the survival. How, by applying this test, you believe that you are cured. But no, that's not the case. You still need something more. And you can see that if you have high risk tests and you give chemotherapy to those patients on high risk, that patient match the low risk population, which is the green line. And you can see what happened if you have this test being on high risk and the patient did not receive chemotherapy because we believe that the patient was cured just by surgery. We know that there is a lot of early stage lung cancer that they have an aggressive behavior. Next slide. And in the other part of my talk, and with this I will finish, is the molecular medicine from this trial called the ADAURA trial, which was presented last year in our Oncology Society meeting in Chicago, and then presented in another analysis in Europe. This is the ADAURA trial. What is this? Okay, patients that went for surgery and they were found to have pathological stage, meaning after surgery, stage 1B, 2, or 3A non-small cell lung cancer, they went to receive adjuvant therapy. Some patients received chemo, some patients did not receive chemo, but all of them were tested for EGFR. And if they were found to have the mutation, they were randomized 1-to-1 to receive osimertinib, which is EGFR TKI inhibitor, tyrosine kinase inhibitor, third generation versus placebo. They analyzed the population based on stage 1B, stage 2, and stage 3. Look how good the patient that received osimertinib did, which is the blue line. All the groups were positive for disease-free survival in favor of osimertinib. And this became the first target therapy that we have approved, not only here in USA, but hopefully soon in other parts of the world for adjuvant therapy after surgery. Next slide. And this is the approval on December 18 by the FDA. Next slide. And with this, I finish my presentation just bringing to you what I consider has been the 3 major developments last year for early stage lung cancer. So remember, think about screening. We can save a lot of lives by doing lung cancer screening. And number 2, bringing now molecular medicine also to early stage lung cancer. Thank you.
Thank you very much, Dr. Santos, for that great presentation. I'd like to remind all the attendees that your presentation is brought by, you can bring questions in the questions box in the chat. I see that some people are already putting some questions. As I promised, at the end of the presentation, we're going to do a small panel, a Q&A, and we're going to answer all the questions. Next, we're going to hear Dr. Rodriguez, who's going to turn her webcam, and she's going to talk about management of advanced lung cancer. Please go ahead, Dr. Rodriguez.
Can you see me? Oh, great. Hi, good evening. Thank you for the invitation. And excellent talks by Dr. Rice and Dr. Santos. And we all have, so we are specialists in lung cancer, and this is what we're passionate about. And I think Dr. Rice conveyed very well that we're very excited about it, the progress that has been made. And I'll basically give you a talk more general, just discussing how I approach patients that have advanced lung cancer. So we do know that about 3/4 of patients that present with lung cancer will have advanced disease where we're not going to be able to offer them surgery, but we have better and better treatments for them. And we have seen in our lifetime that lung cancer, instead of being something where people progress really fast, and there had been a time here decades ago where patients were not even referred to oncologists. Now patients are living longer, and lung cancer is becoming a chronic disease. So I will give you this talk from the perspective of you being a new patient that comes to an oncologist. What are the things that you want to discuss in your first visit, and what are the things that we are looking forward for the future? Next slide. So Dr. Reyes gave you a nicer slide that covers this topic. Basically, when you see your oncologist in your first visit, one of the most important things for us is to understand you, but also to understand the cancer. And in the past, on the left, we only divided the pie in terms of like how the cells look under the microscope. So we know the majority of cancers were adenocarcinoma, which are non-small cells. And then we had a smaller group that was small cell lung cancers. And that's where we ended up, and we kind of gave everybody the same chemotherapy approach. And in a large trial, ECOG trial, we know that this approach didn't get us anywhere. Most patients with different chemotherapy, platinum chemotherapy combinations were getting the same outcomes. It wasn't really until we have the ability to understand deeply the molecular changes that led to the tumor that we were able to make more progress. And it's also important to pick chemotherapies that are more likely to respond if cancers are adenocarcinomas or squamous cell carcinoma. So the pie in terms of like what we see in terms of molecular subset, this is getting further and further characterized. And really, in my lifetime, we now will know that not only is a cancer, but we really understand the genetic makeup of that cancer so that we can offer patients better treatments. Next slide. So when I meet patients in our first visit, I first want to get a pathology review. And sometimes that is very important because we make our treatment decisions based on that pathology. The second component that we discussed about is that we want to understand the genetic makeup of the tumor. And now that we have the ability of doing liquid biopsies, which we can do the same day that we meet the patient for the first time, we're able to characterize the tumor within 7 to 10 days in terms of molecular pathways. And that will really allow us to divide, understand where you fall and what treatment options we have right now that would be best for you. So if you have a tumor that has one of these drivers, and we know that many of these oncogenic driver tumors are found in never smokers, but they're found in any patient. We have seen them in smokers, we have seen them in squamous cell carcinoma. So doing that mutation analysis is really critical. Then the next marker that becomes very critical from the get-go so that we pick the best treatment for you is to understand how likely you are to respond to immunotherapy by doing a PD-L1 marker on the tumor specimen. And we can do that in the tumor biopsy, not in the blood. But that would allow us to, if you don't fall in the group, which is about, I would say 20% of patients that have drivers, then you're in this category of patients that we can treat either with chemotherapy or immunotherapy or the combination. And I think right now, what we have seen in the last 5 years is that we're moving farther and farther away from chemotherapy alone as a treatment for advanced lung cancer. We're able to get better and similar results with either immunotherapy with chemotherapy or immunotherapy alone. So once we know that you have an oncogenic driver, we have a discussion about what is the best first line targeted therapy, which are usually pills for you. And Dr. Reyes talked about the fact that just in the last year, we are able to offer patients that have MET, exon 14 skip mutations, and RET mutations a new treatment option that is one of these targeted therapies. And these are patients that really 2 years ago didn't have this option. So really the science is moving fast, and it's very exciting that we can detect the mutations and find the treatments that will work best for those mutations. Then we talked about patients in this end that have a very high likelihood of response to immunotherapy, and those patients we have in our cohort trial, we know that those patients don't need to seek chemotherapy. We can treat them with immunotherapy alone. And I think the challenge for us is two things. One is that we have several immunotherapies that have been approved in this setting. So we will review with you what would be the best immunotherapy from our perspective for you, but there's several agents in the market and they have different trials that got them approved, but they are all effective. And then we understanding which patients will respond best to that and that don't need to seek chemotherapy. Now, once we have gone down the line of immunotherapy alone, and we do that from the get-go, then it's very important to talk to your doctor about clinical trials because there are some patients that respond for a long time, and Dr. Reyes showed that data with long-term responders over 30%, but there are patients that progress. And we know that if they initially were able to respond to their cancer just utilizing your immune system, there's a lot of research and clinical trials available in your area about how to wake up the immune response again, and new immunotherapy agents are being developed as we speak. And then I would think about, so this is about 20% of patients, and then about a third of patients will have this high expression. Then everybody else falls in this group where they have some expression of the immunotherapy receptor where immunotherapy can work, but maybe not fast enough when we combine it with chemotherapy. But now we have data that perhaps using double checkpoint inhibitors, which are two immunotherapies that work in different mechanisms, maybe we can get the same results that we will get with chemotherapy. So really, when in the past we had patients, most of our patients with lung cancer are elderly, they have other comorbidities like COPD, and some of them are in oxygen. So the fact that we're able to treat patients now with targeted therapies, which are pills, which are very well tolerated, and also that we are able to offer patients immunotherapy by itself, which doesn't have the side effects of chemotherapy, it really has been a game changer in terms of how our patients can tolerate treatment longer and they can benefit. Next slide. So this is the evolution of EGFR mutations and their treatment. And we can show you similar fast evolution in research that has been done for all the other mutations. And I think what I will say is that from the first time that these EGFR mutations were identified and started in clinical development, now it doesn't take as long. It took several years for the first patients to be treated and for the drugs to be developed, and then for us to understand how to use them, which was that patients needed to use these medications when they had the mutation. We had given, one of the first trials that was done was VR21, where they gave the erlotinib to all patients, and obviously not all patients respond. Now we know you have to have this mutation to respond better. But just to show you how patients have benefited from this research, the first trials were showing benefits, the targeted therapy versus chemo. So we have large international trials that show that if you're found to have this mutation, you're better off starting with the targeted treatment up front and not in chemo. And it's important to know that. So sometimes we meet patients and we're eager to start treatment, but we do have to wait, because if you need a targeted treatment and we give you immunotherapy just to start something with chemotherapy, we can cause more side effects when we find that you need a targeted treatment. These medications can cause, when you do them in sequence, they can cause more pneumonitis. So it is very important to us that we start the right treatment from the get-go, and you will do better like that. We have, what I also wanted to show you here is that we have gone through several generations of this drug. So in the past, while most of our patients were getting erlotinib and afatinib, we're experiencing a lot of skin and GI toxicity. Now the newer third generation drugs have less of that. They are being developed to target resistant mutations. But this is an ongoing area, and the more and more drugs. There's a fourth generation drug that was approved in the first line setting recently. And now we're looking at drugs that will target 3 or 4 resistant mutation mechanisms at the same time. So there's a lot to come for patients. But I will tell you that there are patients that were started on gefitinib that are still with us. There are patients which are more than 10 years ago. There are patients on erlotinib that have been long-term responders. So this really has become a chronic disease. So understanding those mutations so that you can get on the right treatment from the get-go is important, and it means a lot for your survival and your do over time. Next slide. So the next slide is just to show you the very exciting progress that has been made on immunotherapy in lung cancer. And it has been a revolution that we are able to treat patients earlier with stage 3 disease, patients with small cell lung cancer, and patients in the second line setting first, and now in the first line setting. And we were able to replace chemotherapy like we did for patients that have a high expression of PD-L1. And just to show you that the development of this we will have more and more drugs developed. Just about a month ago, we heard that there was accelerated kind of, not approval, but like the FDA is considering new immunotherapy. So we were talking about checkpoint inhibitors, which are PD-L1, PD-1 inhibitors, and CTLA-4, but now we have a new category, or anti-TIGIT antibodies and immunotherapy. So there's new agents that will come very soon, and that we hope will allow us to offer patients, less patients will need chemotherapy, and patients will get more long-term responses to immunotherapy. Next slide. So Dr. Reyes kind of covered this exciting trial, which is the KEYNOTE-24 trial, that was really one of the first trials that tried to, test this idea that we can replace chemotherapy on patients who were very sick with lung cancer, advanced lung cancer. So this is a trial that selected for patients more likely to respond. So they had a PD-L1 expression of more than 50%, so that the cells had these receptors that were blocking the immune system, and we were able to use pembrolizumab, which is a PD-L1 inhibitor that will bind this receptor. We were able to get longer responses and faster responses, and we showed that more patients were alive at 1 year. Here, and Dr. Reyes in his curve shows that response has remained over 5 years for patients. Now, we do have patients that progress in the second and third year. And our challenge and the clinical trials that we want to offer our patients are those for what can we do to wake up the immune response, what other agents we can use at that time. Next slide. So the KEYNOTE-189 trial is another landmark trial that really tests the most commonly used combination of chemotherapy and immunotherapy in the United States. So this trial took all comers, patients that were likely to respond to immunotherapy, were patients that we thought would not respond as well, and they gave them immunotherapy from the beginning with chemo. And this was a little bit controversial because the idea that we will give chemotherapy that will decrease the immune system and at the same time try to enhance the immune response with immunotherapy seemed contradictory. But it did show that from the get-go, even if you have a low expression or middle expression of these receptors, you will respond better with combination of immunotherapy with chemotherapy. Now, we do see that there's a group of patients that at the beginning, especially if they're very sick and they don't have a lot of receptors, they would benefit from having chemotherapy before they see the benefit of immunotherapy. So a lot of our patients that have low expression or middle expression or are very symptomatic, since we know it can take some time to build that immune response, we favor using chemotherapy for now. But that will change because we have new immunotherapy combinations that may change that paradigm. The other thing I wanted to note about this is that one thing that has been very important in the last year is that we have gotten approval for a lot of these immunotherapies to be used at a longer interval. So once in this trial, once you had 4 cycles of chemotherapy, immunotherapy, you could continue on immunotherapy by itself with or without one of the chemotherapies called pemetrexed. And many of our patients during this whole COVID pandemic, we struggled about what to do. They were stable. Do we continue the chemotherapy and immunotherapy combination? Do we hold the treatment not to expose them to more immunosuppression and risk from coming to the cancer center? And, you know, months into this pandemic, we have learned that lung cancer continues and holding the treatment is not really the right option for most of our patients. So we're glad that we can now offer patients this pembrolizumab immunotherapy every 6 weeks, every 4 weeks for atezolizumab. So there are now ways that we can continue immunotherapy and you don't have to come as often to the cancer center. And I think that that's something that we started doing because of COVID, and I think it's going to stay in our treatment paradigm for patients. The other point that I wanted to make about this trial and many other trials of immunotherapies, and the original trials, patients were the treatment was given for up to 2 years and then stopped. And we do know that some of the patients who had stopped that treatment at 2 years continue to respond without receiving anything else. And that really is very exciting because it's really the first time that patients with advanced disease, we can say, could be responding, and I will say some patients cured without treatment, and that's something that had never been the case before. So what to do when we get to that 2-year mark is a conversation that we have with many patients, because there's a group that probably will be fine if we stop. For more and more of our patients, especially if they started very sick, will continue, and now that we can offer them these longer interval treatments, continuation of treatment after 2 years seems like a very reasonable approach. So that's a conversation that we have and you can have with your doctors. Next slide. So this is another immunotherapy option that has been approved, and I think it's very exciting because this is just again the idea of replacing chemotherapy altogether and using immunotherapy alone. And this is a combination of 2 checkpoint inhibitors that have been used for a while in melanoma, and now we're able to use them in lung cancer in a protocol that makes it easier to tolerate. The primary endpoints here were overall survivals, and we saw that for all comers, patients that had more than 1% expression, so the high expressors and the middle expressors, they did have a benefit to being in the immunotherapy arm alone. But at the beginning of it overall, it sounds like there are patients that still benefit from chemotherapy from the beginning. And the next trial, which is CheckMate 9LA, was testing the idea that maybe there's 2 cycles of chemo to kind of cover those patients that need chemotherapy up front and then stay with the checkpoint inhibitor combination is the right approach, and that's also something that is approved. But we did see there was a longer duration of response in all of this overall survivals for patients that were more than 1%, and even the ones that were less than 1%. It's really impressive that the immunotherapy response continues and the benefit is prolonged. So again, we're getting closer and closer to replace chemotherapy, but chemotherapy still may play a role in patients who are very symptomatic early on. But we're able to offer chemotherapies that are better tolerated and perhaps maybe treat patients up to 2 cycles in continuation of this checkpoint inhibitor combination. Next slide. So the other point that I wanted to talk about, and that's something that the patient and the family has to be informed is that in the past, we were very used to following patients on treatment, and since it was only chemotherapy, we will have these discussions about how to manage nausea and how to manage neutropenic fever, which are fevers that you may get during the treatment. And that was kind of the end of the discussion. And some of those side effects can be very serious, but we have gotten very good at managing them. Immunotherapy has really challenged us because immunotherapy, when it wakes up your immune response, you can make antibodies that will attack the tumor, but you can also make antibodies that attack your normal tissues. And we have seen immunotherapy toxicities and kind of immunotherapy side effects that relate to almost every organ in the body. Now, these things are, for the most part, not as serious, and patients do better with immunotherapy when compared to chemo, and they can tolerate it longer. But it's important that we recognize that these are different side effects and that you need to bring them to the attention of your doctor. So I will start head to toe. We have patients that have described having dry eyes, and that actually can be a side effect of immunotherapy that we may need to manage with steroids. We see a lot of skin toxicity that is mild. So some patients described in the first day of the immunotherapy, they may have pruritus, which is itchiness of the skin, which is very short-lived and can be managed. But there have been cases where we have to be more aggressive. We have seen also that when you wake up the immune response, you can get vitiligo. And vitiligo is an immune response that you get to the melanocytes, or the cells that give you color in your skin, so you can get these white patches over your skin. And that's not a very serious side effect, but you will notice. And we have patients that have been on treatment for a long time that have this. I would say the more serious side effects that we need to know about are GI side effects. So if you're having diarrhea more than 4 times a day, and urgency, this is something that at night, on the weekends, you have to call the doctor on call because it could get out of control, and you will need to be treated with steroids urgently. And this is something that, these are the reasons why we have seen people be admitted to the hospital, GI side effects. And the other one has been lung side effects, which are pneumonitis, inflammation of the lungs that would cause shortness of breath. Now, lung cancer patients may have shortness of breath at baseline, so it's sometimes hard to differentiate what is an immunotherapy side effect from the underlying cancer. But if you're having a rapid development of shortness of breath or a big change in how you were breathing and walking around the house, we will need to know about it so that we can do imaging studies and check your oxygenation. I will say that one of the things that I learned now that we're doing telemedicine with our patients, I have learned that we can have these conversations by telemedicine and kind of monitor the side effects more often, which has been useful. I have asked many of my patients to buy one of these pulse oximeters so that we can monitor their oxygen at home and really get a sense if this is really a pneumonitis that will make you short of breath. And then there are other patients that experience fatigue, which can be transient, but there's very serious endocrine side effects related to your thyroid gland that can cause fatigue, and the adrenal glands, which can drive adrenal insufficiency. And those things we need to know about, and they can be subtle, but we do test for some of these hormone levels as you come in for treatment so that we can be on top of it. And then rarely we have seen immunotherapy side effects that affect the immune system. But again, every organ can be affected, and that's why I say if you notice anything that is new, it's best just call, and that we can go over and discuss and decide together if it's something that we need to treat. Next slide. So I will just end here just to tell you that, Dr. Reyes did mention that in the last year that has been very traumatic for many of our patients and all of us. Really, the development or in the approval of new drugs has been unprecedented for lung cancer. Now, these drugs were developed not because in the last year we did more research. They were developed because in the last 10, 20 years we have invested money in research. And that's why it's so important that you as a patient and as a family member, that you advocate for more research funds for lung cancer, because we know that lung cancer is the #1 cause of cancer death, and it doesn't get the top amount of money that we need to really move the science. But the other thing I will show you about this slide, that when we were stuck in the 70s, 80s, and 90s, we were stuck with chemotherapy. Now we really have many, many options for our patients, different generations of these targeted treatments, and in the development of immunotherapy. So really the future looks very bright, and to be a cancer patient, to be diagnosed today, we have a lot to hope for. And that's all I wanted to say. I did want to cover COVID, and I did mention to you how we have approached it in our clinic, where we have increased the interval of treatment. And I will say this before we get into it, we do recommend the COVID vaccine for patients on chemotherapy and immunotherapy, but I'm sure we can go over that later. Thank you.
Thank you very much for the presentation, Dr. Rodriguez. And now we're going to hear from Lindsay, who is going to turn her webcam, and she's going to discuss also a very important topic is the patient assistance programs and caring from the caregiver. Please go ahead.
Hello, my name is Lindsay Nienbrink. I am an oncology social worker, and I am going to be discussing with you patient support, financial assistance, and caregiver support. Now, as a patient or caregiver, there are many resources available to you, but how do you know what they are and which ones would be appropriate? If I were to come to you as a patient and give you this long list of resources, it would be very overwhelming. So that's where the social worker comes in. It is very important for you to utilize us. Most major cancer centers have social workers. If you are at a smaller cancer center and they don't have a social worker available, that's okay. There are resources that you can reach out to, such as the American Cancer Society, and then they can link you up with more appropriate resources. Or Cancer Care is another great resource as well that you can call, and they'll provide you with resources. But if you do have a social worker, ask to meet with them. And then what do we do when we meet with you? A lot of times when I go and meet with patients and I tell them I'm a social worker, they say, okay, well, what can you do for me? So when we meet with you, we're going to start with where you're at. We're going to assess your situation, again, to kind of narrow down what resources we feel are appropriate for you. And throughout your cancer journey, whether you're beginning treatment, during treatment, or when you move into survivorship, your resource needs are going to change. So we're probably going to meet with you throughout your cancer journey to provide you with those appropriate resources when the time approaches. Now, when we meet with you, we're going to assess different things. What's your home situation? Who do you live with? Are you currently driving? Do you have transportation? Are you independent? Are you using any medical equipment? Do you currently have home care? What's your support system? Do you have friends and family locally? Are you currently having high distress? Any history of anxiety or depression? And once we know these key points, we can then make the appropriate referrals. For instance, transportation is a huge one. A lot of patients come to me, and even if they can currently drive, they're worried that throughout treatment, they might not be able to drive. And if they don't have friends or family locally, they're concerned about how they're going to get to treatment. So there are resources. In Broward County, we have TOPS, and the social worker can help you fill out the application for that. In Miami, I'm sure they have a transit system as well that the social worker can help you apply for. The American Cancer Society has a transportation program. It was closed down for a little bit because of COVID, but I think it's back up and running. It's an application process, and the social worker can help you. And then utilize friends and family. If they're around, a lot of times friends and family, they want to help. Give them a job. Say, you know, I can really use help I need a ride to treatment. And then family wants to help as well. Home care. If you're not currently, you know, having home care, and you may not need home care, but knowing that it's available is very helpful. And the social worker can help to arrange home care through insurance. Any medical equipment you may need, we can help arrange that through insurance as well, whether it be a walker, a wheelchair, or oxygen. We can help you with that. And then the main thing, the one thing that we're always looking out for is emotionally, how are you doing? Having a diagnosis can be very overwhelming, anxiety inducing, whether you have a history of anxiety or depression or not. Getting a diagnosis can then exacerbate it or create anxiety. Throw in a pandemic and you're going to have a lot more anxiety. So we kind of want to see where your anxiety level is at and then give you resources to help that. Lung Cancer Alliance is a really good resource. There's a website called lungcanceralliance.org. You can go to it. They have research on there, they have information, they have a peer support program that you can get linked up with somebody else who has lung cancer. You can talk to them over the phone, which is very convenient right now. You can do it from home. The Fourth Angel Telephone Peer Support is another program as well that links you up with somebody around your same age, same diagnosis, so you can get peer support. And I will say it's really great to have friends and family who offer support, but getting peer support offers a different level of support. Talking to somebody else who's going through it, who's had the treatment, side effects, if any, or can just kind of help you during your journey is very helpful. Many cancer centers have counselors on staff. They have resources in the cancer center, art therapy, music therapy. These are all things that ask the social worker about, see what your cancer center has, and utilize those services. Now, some patients in the beginning of treatment, during treatment, they may not feel that they need any extra support. But even when you're done with treatment and you go into survivorship, these resources are available to you. So always check in with your social worker. You may not feel that you need the resources now, but you can utilize them later. And then if you felt that peer support wasn't enough, or counseling at the cancer center wasn't enough, we can always refer you to a psychologist in the community through your insurance. There's a really great website called psychologytoday.com. If you go to it, you can put in your zip code, your insurance, and it links you up with a bunch of local therapists in your area. You can read about them, see what they specialize in. And again, you have to go through insurance, but it's good to know that it's there. And the social worker can help you with that as well. We get a lot of questions about financial assistance. You know, getting a cancer diagnosis, nobody plans for it. People then can't work, and they're worried about how are they going to, you know, either pay their bills or pay their co-payments, because you have a lot of doctor's appointments, you have a lot of medications you have to fill. They all require co-payments. Some people don't have double income, so they get scared. This causes anxiety, and we want to reduce your anxiety. So there's financial resources. And again, I could give you a whole list of the financial resources, but my goal is to not overwhelm you. So a few that are very important that you can use at any stage throughout your journey. One is needymeds.org. It's for co-payments for medications. Patients will come to me very frantic because they just got prescribed a medication and they have a $900 out-of-pocket cost monthly. And of course, that's crazy for anyone to have to pay on top of all the other things, and they might not be working. So Needy Meds is a great website. If you're a Medicare patient, you cannot go through the manufacturer for the medications. You have to go through foundations. So Needy Meds lists all the foundations for you. Now, if it's too much for you, again, ask the social worker. They can do it. They can give you the list of 3 foundations and go from there, so you don't have to make all the phone calls. As a social worker, we want to take as much off of you as we can. Other financial assistance programs available, such as Cancer Care, they have co-payment assistance, and some cancer centers have their own financial programs. So always ask the social worker, what financial assistance programs do you have? And financial counselors, some cancer centers have financial counselors specifically to help you with that. So you can go and talk to them and ask them, you know, insurance questions and co-payment assistance questions, whether it may not be co-payment assistance but a plan to help pay for certain things. And then another question I get asked a lot is about Social Security disability. So the social worker is there to help you with that. In order to qualify for Social Security disability, you have to be unable to work for a year, and it could take up to 6 months to get approval. So I like to let patients know that, because it takes a bit. So you can have the plan to apply for Social Security disability. Unfortunately, the social worker can't apply for you. You have to call Social Security disability yourself. You can go online and just look up Social Security disability and get the phone number. You apply over the phone. It's very easy, and but it can take up to 6 months for approval. So you can come up with a plan with your social worker. In the meantime, before you get approved for that, what are you going to do? You know, how are you going to get your co-payments covered? Again, Needy Meds foundations, you know, patients who had $800 co-payments, we've brought down to $20. So there are ways. So we want to take some of that stress, because that causes a lot of distress for patients, and we know that. So I also want to talk about caregivers, which are very vital to the patient's journey. I gave a talk 2 years ago on caregivers, and I talked for like 30 minutes on it, but I'm going to try to condense it because I know there's a lot we have to talk about. But who is a caregiver? Anyone can be a caregiver. I mean, anyone who provides emotional, physical, financial, spiritual support is a caregiver. You can be a caregiver from near or far, and a caregiver can be anybody, just because, you know, it's not just a husband or a wife. A caregiver can be a mom, a dad, a brother, a sister, a friend, a coworker, or an adult child. A lot of times, the adult children fall into the caregiver role, which can be very overwhelming. Because as a caregiver, you wear many hats. You do a lot of things. Like Dr. Reyes was saying, you are very important, and you are not forgotten. And we want to make sure that we take care of your well-being, your emotional health as well. Because you become the cook, the housekeeper, the chauffeur. You're taking the patient to the appointments, the accountant, the secretary. A lot of times the caregivers, you know, they have to stop doing their job and now take on roles that they weren't doing. So it can be very overwhelming for them. And We don't forget about you. We know you're there. And, at many cancer centers, a lot of the resources that are available for the patients are available for the caregivers as well. Because we want to make sure, there's something called caregiver burnout. And it's very important as the patient and the caregiver, or anyone who's, watching, who's neither, but has a friend, check on the caregiver, look for signs that they're being burnt out. And what are those signs? Mood changes, eating poorly, they're having trouble sleeping, they lose contact with friends, they're sleeping a lot, they feel anxious, and they, a lot of times caregivers tend to ignore their own health issues because they're so involved with the patient and they're doing such a great job, they forget about themselves. And when you see these things, you want to jump in, whether, again, you're the patient seeing it, the doctor seeing it, a friend seeing it. Jump in and intervene. And what do you do when you see these signs? So you provide them with resources. You tell them, hey, you're doing a really great job, but it's really important that we focus on you. There is support for you. There's caregiver support. There's telephone support for caregivers through the Fourth Angel, which I had mentioned for patients. There's also a dedicated Fourth Angel telephone peer support just for caregivers, which is really good during a pandemic, that there's all these virtual options as well. Gilda's Club, South Florida, is a really great resource for patient and caregivers. They have a patient support group and a separate caregiver support group. And what's so good about attending a caregiver support group is it's a place where you feel safe and you can talk and you can vent and you can talk to other people going through the same situation as you, the same life changes. Now, again, if you see a caregiver who you think is, overwhelmed or getting burnt out, help them, schedule a break for them, come up with a plan for them. Say, all right, Mondays and Tuesdays for 2 hours, I'm going to come help out. You go and do something you really enjoy, take a break. And, if you're a caregiver watching, what are some of those things that you can do for your mental well-being? Meditation, going to a religious event, virtually, if it's not in person, listen to music, read, aromatherapy, music therapy, art therapy. Again, some cancer centers have all that. If you want to see a counselor, that's available as well. Seeing a therapist to talk to can be helpful as well, and just seeking out support. We know it's a balancing act, not only for the caregiver, but for the patient as well. It's really hard. So it's very important that you guys, utilize these resources, utilize a social worker. We are here to help you in any way that we can, and just to make your journey a little bit easier. So thank you.
Thank you very much for the presentation, Lindsay, and for highlighting the caring for the caregiver. And I think I don't have to emphasize, but maybe, as I said, sometimes we forget about the caregiver. It's important, if you're a caregiver, that you take care of yourself, because if you don't take good care of yourself, you're going to help the patient, because you also have to be having issues, and that's probably normal. It's impossible to be a caregiver and be new to the situation that we have to face. Cancer affects each population differently, and minority groups in the United States bear a great burden for many cancers. You have heard about the outcomes in prostate cancer, breast cancer, multiple myeloma for minorities are much different from other populations, and they're very bad. The Florida Society of Clinical Oncology is actively fighting cancer disparities on many fronts. On your cancer journey, you can do that as part of to making sure you only have to ask. So you can help us narrow the gap, and to learn more about cancer disparities in lung cancer, please, you can download our Disparities in Lung Cancer slide packet and Minority Cancer Awareness handout. These are located in the handout drop-down box in the GoToWebinar panel. Yeah, if you see the GoToWebinar panel again, it's in our right side, is where you can put the questions. There are handouts that you can download. I see the disparities for lung cancer handout. It's a PDF. You can also hand out the living with lung cancer, and then the other one. Now we're going to move to the Q&A portion of the webinar. I'm going to read some of the questions that some of the audience is asking. And And then we, when we finish the Q&A, we have a video about the importance of advocacy. And let's start with, can you please, Lindsay and Stella Mari, Dr. Rodriguez, turn on your cameras. We want to read some questions. And please feel free to make any comment. This is a panel, no? For example, the first question is in the audience is asking, let's see, Dr. Santos, can you please go into more detail between liquid biopsy versus bronchial biopsy? What would make a patient eligible for blood biopsy?
Okay, good question. So basically, there is, traditionally speaking, there has been many ways how to do a biopsy for many years. We were the conventional tissue biopsy. So how can we get a tissue biopsy? Could be either a surgery or CT-guided biopsy, which is a needle, okay? A big needle that we put where the lesion is. Sometimes there is another type of needle that we call fine needle biopsy. And bronchoscopy is one of those technologies that we are trying to reach the tissue, okay? Because when we do bronchoscopy, we are dealing with very important structure in the chest. Most of the time, the biopsy are done by fine needle biopsy. And to get enough tissue, we always tell our pulmonologists to do several passes, several biopsy, because the needle is smaller than when we do an external biopsy. And when I said several passes, because we need enough tissue to do the molecular testing. Remember, everything is on molecular testing. So that is all the ways how we can do tissue biopsy. Liquid biopsy, we call liquid because it could be any kind of fluid. The traditional one is blood, but it can be blood, it can be urine, it can be fluid in the lung. We call that pleural effusion. Everything that is liquid. Now, in the regular language, when we talk about liquid biopsy, we are talking about blood. Now, in both either tissue or blood, that technology that we have to use to analyze the tumor and identify those molecular things that Dr. Rodriguez mentioned is something that we call next generation sequencing. Next generation sequencing is a technology that with even a small piece of tissue, we can analyze hundreds and thousands of genes and identify where is the problem from the cancer. So that is the difference between the bronchial biopsy, which is basically tissue biopsy, versus liquid biopsy that most of the time is coming from the blood.
The other thing I would add is that tumors can evolve over time, and we do like to do this test at baseline just to understand the tumor. When things progress, it is important to follow this test, and you can do another liquid biopsy or a tumor biopsy. The liquid biopsy is not informative. Yeah, so that is important. I think now that Dr. Santos talked about the approval of osimertinib targeted treatment in early stage cancer, I think now for all patients that have resectable cancer, we need to understand the mutations as well. In the past, we had only been testing patients that had advanced cancer because we only had approvals for those treatments in advanced cancer. But I think now for every patient, we need to understand more.
Yeah, this is a very exciting for us. Always know that I know lung cancer or my breast cancer in the blood, and I wish we will get to that one day soon. Yeah, we are very close. We are very close because the patients are always right. You know, they said, why you're taking pictures, doing CAT scan every 2 or 3 months empirically, and you don't know when the tumor is back. So it makes more sense, maybe draw the blood, and if you find that the tumor is coming back, even if we don't see, we can start to fight, you know. I learned that from our hematology malignancy colleagues. I remember they do bone marrow transplants, and then the patient is clean, but they don't even stop that. 3 months later, 6 months later, 9 months later, they bring the patient back and they check his blood and they do molecular analysis, and they know long before the tumor shows up in any CAT scan or PET scan that the cancer will be back, so they act right away. No, so that's why I think a lot of our patients that are probably watching, they have this in mind. So we are getting closer, very close. Yeah, Dr. Santos and Dr. Rodriguez already have explained that we can do molecular testing in the blood, and we are very close to one day tell you that the best way to diagnose lung cancer is only doing a blood draw, and but we are not there yet. Another question, Dr. Santos, when we have a lobectomy for early stage, what is the chance of recurrence if we don't do anything else?
Yeah, okay, so have you, if you saw the slide I put on survival, when I see a lung cancer patient in my clinic, I tell them this is a teamwork. It's the surgeon, it's the radiation oncology, it's the medical oncology. It's a team. So don't believe, please, that because you have an early stage, all the work has been done. We need to try to go for surgery and then analyze the entire picture. This question came because this patient asked this because he went through surgery. There was no evidence of disease for 5 years. Unfortunately, the patient had a recurrence in the area where the surgery was done. Very well treated, in my opinion, with SBRT. Okay, that's why we have the technology. And sometimes if the tumor is very small or the recurrence is very small, especially on tumor below 3 centimeters, SBRT can control or maybe cure the patient for a while, okay? So SBRT is very important. What happened to this gentleman? Unfortunately, the same patient that asked this question then developed stage 4, and the patient was exon 19 EGFR mutation, and now he was placed on osimertinib, and now he's stable. And the other question that he asked was, why this test couldn't be done early to prevent progression? And the patient, as Dr. Reyes said, is correct. The problem is that this is new. It takes years to develop those clinical trials to prove the efficacy, and now we have it. Now, going back to the original question from Dr. Reyes, so you have an early stage lung cancer, stage 1 and stage 2, for example. For stage 2, at 5 years after surgery, unfortunately, we have lost 30% of the patient. And why is that? Because what we do is just looking tumor size and looking morphology. But I already told you that every tumor is different from the molecular standpoint and also from the genetic behavior. So there are some tumor, even if it's a small tumor, stage 1 could be more aggressive than stage 2. And that's why we need to apply those tests that we have now to analyze, identify those patients with early stage, even stage 1, and see which patient really need to be more aggressive in the therapy after surgery. So again, Dr. Reyes, it's a very different disease when you do, for example, stage 1 lung cancer and stage 1 breast cancer. And stage 1 breast cancer, female patient, stage 1 could be live more than 90% of those patients at 10 years. In lung cancer, that is not the case. That's why we need to continue doing research and applying all the technology that we have available to save those patients.
I have a question for Lindsay. Do you have statistics how much the caregiver gets affected in a cancer patient? So it's like 10% of the caregivers suffer depression, or 20% get issues. So do you have statistics about that? So how important is this problem?
I don't have a statistic on it, but it is very important, like you said. And as I was saying, I had given a talk 2 years ago for you guys, and I spent the whole time talking about caring for the caregiver because it is such an important subject, and they do kind of get forgotten, and they're doing a lot of the work. So, you know, that's why, you know, where I work, we offer all of our services to the patient and caregiver, and we present it that way because we don't want them to feel that they're left out or that these services aren't available to them, and also to prepare them, meaning moving forward, you may need some of these services as well. So they are available for the patient and the caregiver moving forward.
Oh, great. Great.
Yeah, I think I would emphasize that I when I take care of patients, you know, through their journey, And I really, we build this relationship with caregivers. I've seen that patients and their caregivers don't ask help. They don't ask for help as fast as they could. And, you really see people struggling and being isolated during the COVID times. And, most of our offices have social workers and services that are available to you, but you also have family and friends. And I've been always impressed by, the family can come together and you just have to ask for help. Every
Well,
little thing helps. Yeah.
Why it's important to know the signs of burnout. Even the doctors, you work as a team, so everyone needs to be aware and, looking out for the signs of burnout. And the caregiver, when they're accompanying the patient to the appointments, do you see them acting differently? You spend the most time with them as physicians. If the caregiver, now they're not really allowed to come, but as social workers, we talk to them on the phone and we can kind of tell, they open up to us. So we see if there's a difference in their personality, or if they sound tired. We say, what are you doing for yourself? What do you like to do? Are you still doing your normal activities? Kind of assessing them without making them feel, that we are. But we do like to focus on the caregiver because it's such an important role. It's such a vital role, and we do want to make sure that they're okay.
Yeah, I think I like this topic because I didn't realize how important is the caregiver before, no? Because I used to say, ask the patient, do you have anybody to bring you every day for radiation? The patient said, yes. Oh, great. I said, this is a great family, great social support. But then the caregivers start to bring to me FMLA forms, no, family back forms. And they said, please fill the form because I'm going to be only work part-time until my mom, for example, finish radiation. And I said, oh, well, be careful. Maybe you're going to get in trouble in the future, but there was no way because otherwise the relative cannot come for radiation. I had another caregiver that told me just 2 or 3 weeks ago that she's quitting her job to take care of her father, And that's why it's amazing the impact that has in the family. So it's great to have family support. The survival in cancer is linked also to the support of the family. The issue is sometimes we're so busy that we don't think the price that the family has to pay. And I know that some of our psychiatrists, for example, in support services, have told me that there is some incidence of depression in the caregiver. And as I said, there is no time for us to discuss the caregiver. We're barely discussing the patient in the few time that we have, but now we're putting more attention to that. And I think what Lindsay is important is that we provide these cancer services. In our cancer center, we have also acupuncture, a lot of support services. These services are also available for the caregivers, so they can be well to take care of the patients. No. Yes. Anybody wants to talk?
I was just gonna say it's important to say also that the patient, the caregiver, they kind of feed off each other, and it's important for the patient that the caregiver is in a good mental state, because the way that the patient may respond and their emotional affect is going to be dependent on the caregiver. So if you're not focused, if one isn't well, the other is not going to do well. So that's why it is, like you said, so important, because they are both vital to the patient's journey. So that's just another reason to focus. Focus needs to be on the caregiver as well as the patient.
Yeah, excellent. So, Stella Mari, there's another question here. They say, is the current research focused on lung cancer skewed toward early stage or late stage?
I think obviously the biggest area of need has been later stage, because those are patients that we're not able to offer them a curative surgery. So a lot of we know that if the research moves that if the drugs are approved and they're shown to be effective on patients that have a lot of disease, then we can go and test them on patients with earlier stage disease. And that's really how it has been done. But now, since there are multiple, that's a good thing about competition, since there are multiple companies, for example, with immunotherapy, at the same time that we're seeing treatments approved in the second-line setting and first-line setting for advanced cancer, we are seeing smaller trials before surgery and after surgery. So I will say that it takes longer to see a result in early stage cancer. That's why when you look at the clinical trials and approvals, you see more drugs approved for advanced cancer, and that's because you can show these results faster. In early stage cancer, sometimes we have to follow patients over 3, 4, 5 years. And I think a great point of that is the data for osimertinib in the adjuvant setting after surgery. And one of the questions was that a patient was like, why didn't I get tested before? Well, it took many trials that were inconclusive to find one trial that was positive for that particular scenario. So people are doing the research, but it takes longer in early stage, and that's why we don't see as many approvals. But we want to invest in both areas. We want to invest in screening, which Dr. Santos talked about, and I think that's really going to make us have need less treatment if we have more patients that are cured with surgery.
Great. Dr. Santos, can you talk about the COVID vaccination of our patients? Should the lung cancer patient get vaccinated during the treatment?
Well, listen, as everyone knows, and I am telling my patient, we don't have data on that because these vaccines were developing under a truly emergency situation in the entire world. And you see the amount of thousands of people that have been dying. So at this moment, there is no data for that. But as Dr. Estela Mari said, we recommend vaccination. Even if the patient is getting either target therapy or immunotherapy or chemotherapy. So especially the lung cancer is a disease. Most of our patients are above 65 years old, and we know that the most important risk factor of mortality is age. And as we become older, then other problems such as cardiovascular disease, the problem with the kidneys and diabetes are coming too. So patient with lung cancer, and especially the patient was a smoker, is also carrying a lot of comorbid condition. I will say that our patient will be safer getting the vaccination if they can as soon as possible. And I think that's what we add. I don't know if Dr. Rodriguez would like to.
I think I would add to that because many of us have had the vaccines completed. I myself had fevers for a whole day after the second dose. And I think, for my patients, if we have a choice, I'm trying to ask them to get the vaccine kind of not around the time of the treatment, but like 2 weeks after, so that we can observe for side effects. But most patients are tolerating the treatment very well. And actually, as you're older, you get less of that immune reaction. So all of the big societies, the Society of Oncology, the Society of Immunotherapy, they all recommend that we vaccinate patients because we know that we'll be able to save more lives. But I think I can't stress enough that really what protects patients has been quarantine and isolation. And I think that's why even if you get the vaccine, we're still recommending that people take all the precautions that they'll be taking, because many of us are here today because we've been taking those precautions. I mean, every time I tested myself for COVID during this whole pandemic, I was in shock because we've been exposed, but I guess this proves the point that wearing a mask and washing your hands makes a big difference. So I think for the patients and their family members, we need to protect our patients who are at home immunosuppressed. If patients are on treatment, you really need to still protect yourself. And hopefully we'll be able to have everybody vaccinated, all the caregivers and the children in the short term. So I think that will come in the next couple of months.
Yeah, I think it's important, the vaccination of the patients. In my perspective is that first, the vaccine is not alive. The vaccine is not the virus itself, We have vaccines like, there is a type of influenza vaccine, the one that we give in the nose, the virus is alive. It's only attenuated, but the virus is alive. That's scary, especially talking about COVID. So that's why this is not the case. The vaccines that we are using in the United States, Moderna and Pfizer, are a piece of the virus. It's a piece only of the RNA. So there's no chance that you get COVID or anything like that, even if your immune system is down. Even if you are chemo, you will never get COVID because it's not the virus. It's only a piece of the virus. And patients are well read. Some patients said, okay, but if I'm on chemo, for example, there is another question that's very related. A patient with the stage 3 is getting chemo radiation. If he's on chemo or radiation, the immune system is down. It is true. The immune system is not a response to, but it's better than nothing. Better than nothing, because as you know, there is a logistically difficult to vaccinate everybody in America. We are 300 million people to vaccinate. So some people are going to be vaccinated at the end of the year, probably. So that is why take advantage of the opportunity, because if you miss the opportunity this week, your next opportunity may be next month. And remember, the vaccine doesn't work right well. The vaccine needs to be given twice, so probably 2 weeks after the second vaccine. So 5 weeks after the original vaccination is when it works, because that's what we did the statistics. These vaccines are 95% successful 5 weeks after the first shot. That's why it's important to vaccinate as soon as possible, as soon as you have the opportunity. And all of our cancer centers, you know, Lindsay is from Cleveland Clinic, Dr. Rodriguez is from University of Miami, Mount Sinai, Baptist, everybody's vaccinated. For now, we're doing 65 and above. Some of them have started to do below 65, but please get vaccinated as soon as possible. It's a matter of safety. The mortality of the COVID is very high among lung cancer patients. It's extremely high because, as you know, a lot of lung cancer patients already have COPD. Now they have lung cancer damage, and on top of that, the COVID gives a lot of respiratory issues. No? I have a question for Lindsay. One of the patients wants to know if you can spell the financial assistance organization or website that takes care of the co-payments or helps with the co-payments.
It's www.needymeds, NEEDYMEDS, needymeds.org.
Oh, that's easy to remember. Needymeds.org.
Needymeds.org. And then.
Oh, perfect. Thank you. Stella Mari.
Yeah.
There's another question. Once that you start treatment for advanced lung cancer, how you know the treatment is being effective?
That's a great question. So we tend to follow the protocol that is used for the trial that got that drug approved. So in many of the trials, they do a lot of imaging because they don't want to they don't want to keep patients on an experimental drug or a new drug if it's not working. So many of the trials do another CAT scan after 6 weeks when we're in the middle of the induction, and then they do another CAT scan after the 4th cycle, which is another 6 weeks, and then they keep following patients every 3 months. However, during COVID, I have learned that that's what's done in a clinical trial. Patients are feeling well. We don't need to test them if we are very stable and have been in remission. However, there's some things that I have learned from Dr. Rice as well that we are very cautious about. Brain progression. We know that we can treat brain progression early, and sometimes waiting for a symptom is too late. So I know Dr. Rice does a lot of imaging very frequently for the brain in patients with advanced cancer, so he doesn't miss the opportunity. And I have learned to do the same because we have really made a difference for patients before they have symptoms. But in general, we know that you're responding because the tumor is shrinking or the size of the tumor is stable or there's a reduction. And we follow that in CAT scans and PET scans. I do more CAT scans and PET scans in the follow-up. MRI of the brain is an area where we do, even if you don't have symptoms. But obviously, if you feel well and don't have any new symptoms, those imaging studies can be moved if you don't want to come in. But again, that's what I do, and everybody here probably has their own take on it.
Great. There is another question for Lindsay. Can you give the website name for locating therapists or counselors?
It's www.psychologytoday.com. So psychologytoday.com.
Oh, great. Then there is another question here. Dr. Santos, I'm having a biopsy next Friday. Is the second biopsy is very concerned not having anybody in the recovery room with me due to COVID. Any suggestions?
Yeah, I assume that the patient is asking perhaps to have a family member with them in the recovery room. Well, you know, even before COVID, there are some recovery rooms in which no family are allowed. It depends. If it's just after surgery, there is a extreme close monitor for those patients. No one is allowed that, and then there is a step down in which the family member can be. However, just to reassure this patient and exactly what we are talking about, our hospitals, okay, and I have been able to practice in several of the hospitals here in South Florida. All our hospitals are taking a lot of precaution. I can assure that a patient that he will not be alone. He will be trained. It will be with nurses that are very well trained in this situation, And by this moment, after living with this COVID almost a year, we are very savvy on how to handle that. So don't be scared. And the message is for everyone, because all of us, we have seen how patient has been scared to go and see the physician, the primary care, the medical oncologist. And unfortunately, I'm pretty sure that the two of you, as well as me, we have seen patients coming too late when the patient had a possible curable disease maybe 7, 8, 9 months ago when this pandemic started. So if you are going for a biopsy and if you need it, please go. Don't be scared. You will be well taken care by our colleagues in that hospital, wherever hospital is there, especially if you are here in South Florida, where we have great hospitals.
Yeah, I also want to ask a question. We cannot lose the perspective that the best way to eliminate lung cancer is to stop smoking. 80% of the lung cancers probably will disappear, and another 20 other cancers if we stop smoking. But the next step before to go for immunotherapy, all of these fancy things that we're talking tonight, is the screening. And I think I want to emphasize the screening. So if Stella Mari, can you emphasize what is the criteria for screening? So if anybody that is listening qualify, can go and get it done?
Yeah, so the screening trial was a very large trial that randomized patients who were high risk. So high risk were patients that were 55 to 75, but some of the guidelines and the insurance companies cover up to 80. And you have to have been a former smoker in the last 15 years, that were a heavy smoker 30-pack years, or a current smoker 30-pack years. Now, and then once you were in the trial, you would get a counseling session in case you need a smoking cessation, and then you would scale for these 3 scans. We detect most of the cancers in the first scan, but it's important to do the other 2. They're done once a year with low dose CT, which is a CAT scan that has less radiation. And it really showed that patients that were in the arm of getting the screening with the CAT scans had a better survival because they were diagnosed with lung cancer at an earlier stage where we could offer them surgery. But it is important to get that test at a place that understands the management of pulmonary nodules, because there were also a lot of patients that had false positive tests where they had nodules and things that were not cancer. And it's important to be in a group and in a hospital that really has experience to evaluate those scans. But I think one of the things that we have learned is that the criteria for screening is not enough. It misses a lot of patients that could have been saved with screening. And now the new proposed guidelines will go to 20-pack year smoking history, because we know that many women and African Americans can present with very large tumors at a less smoking history, and really to not offer them a screening test is not right. So I think in the next year and a half, we're going to see the screening be approved for patients that have smoking history that is not 30 years or maybe 20 years. Yeah. But I find that our patients who are smokers, they don't usually smoke alone. So I always tell my patient, you were diagnosed with cancer. This is what you're dealing with. You have friends who who also are candidates and should be screened. And I think that one of the things that we can do for our community and our families, that you know people in your family, in your community who are smokers. There's a lot of stigma and people don't want to find out, they don't want to go to a doctor, but this is really a life-saving test, the same way that we do mammograms every year. So not to be afraid and to really talk to your doctor, your primary care doctor, about screening.
Yeah, I want also to emphasize that this is covered by insurance.
Yeah.
And it can be done in any hospital in the United States, certainly in South Florida. And if the patient doesn't have insurance, doesn't matter, because all of our institutions here that we're talking, Cleveland Clinic, University of Miami, Mount Sinai, Baptist in South Florida, Broward General, Memorial, all of us have programs. Okay, if you don't have insurance, and only for $99, you can get it done. $99, the price of a CAT scan is like $800, $1,000. This is only $99. All of us are trying to do this for the minimum to give the patients access to the screening. And the idea is instead to diagnose stage 4, because most of the patients that we diagnose these days are stage 3 and 4, and most of them incurable. We diagnose stage 1 and 2 that can be cured with surgery, and certainly now chemo and target therapy. So that is why this is very important. We are only screening 4% of everybody that needs to be screening. So if you see, for example, the colon cancer community, working very hard. They have a 5-year plan to achieve 80% of the screening in 2 years from now. We're only in 4. So I don't want to wait 30 years to reach what these guys are doing. The same with the mammograms, you know. And if you compare the benefit of the lung screening, is more effective in percentage than the benefit from the mammogram, the pap smear, even from the PSA, that is not even mandatory anymore. So that's why this is very important. We are going to be repeating this over and over until everybody's tired for the next 20 years. But this is for now the best way that we can catch lung cancer. I hope that one day we'll tell you forget about lung cancer screenings, now get a blood draw and we'll tell you if you have cancer or not. But as I said at the beginning, we're still not there yet. Okay, so that is why we still have to wait. And can you say a couple of words, Edgardo? We're getting close to the end, about side effects of this target therapy, immunotherapy, compared with chemotherapy, because every time that we diagnose a new lung cancer patient, even now, the family always asks me, but is this worth it? You know, it's going to suffer. It's going to suffer a lot of. So, like a lot of people believe still that the treatment is so harsh that maybe it's not worth it to do anything and only leave the patient in palliative care.
Yeah, thank you, Luis. So there is no question that the evolution of lung cancer therapy has significantly improved in the last 10 years already, with the advent of those target therapy. And the first one was EGFR. I'm going to just quickly use what Stella Mari said about the osimertinib, and the gentleman that said, like, why we didn't use that before. Well, number one is the time that it takes to develop to the drug. And the reason why now we have this osimertinib in the early stage and also at the late stage is because in the past, they were first generation, a little bit more toxic, second generation, and third generation. So every time that we advance any particular drug, any particular pathway, the idea is to get more efficacy and less toxicity, but it takes time, okay? So when you compare target therapy, the efficacy is great. As I can recall, and you can correct me if I'm wrong, but every single target therapy that we have in lung cancer has improved, all of them PFS, progression-free survival, over chemotherapy, and some of them already has also proved overall survival over chemotherapy. So when you see and you balance, you know, the easy way how to take just a pill, a tablet at home, rather than to go to the clinic or the hospital to receive an intravenous medication, it may have a big difference, not only for the patient, but also for the caregivers. So that is target therapy. And then in 2014, we had the first immunotherapy, and now you see the avalanche of immunotherapy agents that we have now, different toxicity, but also improving overall survival, which is the key point of any kind of therapy in cancer, to improve survival. So when we have to choose between therapies in lung cancer, the three of us and all our colleagues, we are looking immediately into, okay, if this patient has a driver mutation, so I can go target therapy or not. And if not, we go on immunotherapy. And then we rely chemotherapy as a second back. So the chemotherapy goes in the algorithm of lung cancer to a lower place just because the toxicity is coming to, plus all the things that Lindsay spoke, and all the hassle for the patient. So I will say that at this moment, those are the two major things that we have in lung cancer, and there is no question that toxicity-wise is less and is worthy, rise, is worthy because we have patients, you, Stella Mari, with EGFR, ALK, living 5, 6, 7, 8 years patient, 9. I met recently with the two of you 2 years ago, Dr. Reyes, you have a patient with a stage 4 lung cancer that is like, what, 16, 17 years since diagnosis? I mean, this is the idea, to make lung cancer an incurable disease or a lethal disease, a diagnosis, making a chronic disease. And that is why we are moving forward, and with advances that we are making slowly, I think at one point we are going to get to the goal.
Great, thank you. The last question goes for Dr. Rodriguez. It's about secondhand smoking. If you have a non-smoker that lives with a smoker, what is the chance to get lung cancer?
So secondhand smoke, I don't have an absolute number, but we do know that secondhand smoke, it is a risk, especially if you have been in a household for many, many years that you've been exposed. It's not the same risk because you're not inhaling, but it is a risk. I mean, they have been, I remember in an epidemiology class that looking at trials of actually the pets of smokers that may have lesions in the lung that could be early stage cancers. So I think, you know, obviously we have made a lot of new regulations that when you're outside in public spaces, you won't be exposed, but in your house, it's kind of hard to enforce. But I think for your health and your loved ones, it is important to protect, especially children, from other toxicities from cigarettes, smoking, heart disease, and cigarettes cause damage to many organs, not only lung cancer.
Great. Dr. Santos?
Yeah, and don't blame the cigarette only, vaping. We need to avoid vaping because people believe that by using this vaping, they're going to reduce the lung cancer. No, it's the same. Every fume that goes to our lung will cause damage to the lung parenchyma, damage to the lung tissue, and chronic inflammation will end up in cancer. So vaping is one of them because it's the fancy stuff right now. We need to avoid vaping also. And we live in South Florida, a lot of people from Latin America. So if you talk to your family over there, the issue of cooking also with wood and inhaling all those fumes also predispose patients with cancer. So I would say, Luis, that any kind of fumes will affect lung cancer and will predispose the patient to develop this disease.
But I would say that one thing that we have learned is that lung cancer is no longer a smokers only disease. If you have lungs, I mean, we see people who never smoke, who are marathon runners, who are being diagnosed with cancer. So that's why we now can diagnose the reasons why that happens, those mutations that happen in those patients who are non-smokers. So if you have symptoms, breathing symptoms that don't get better, you do have, even if you're not a smoker, you have to seek help and get imaging of your lung.
Yeah, that's totally true. And also, there is another question about we should be screening the second-hand smokers. That the idea of the screening is that it's for high-risk people because we cannot do CAT scans in healthy population. You know, because somebody asked me, why we don't do CAT scans in everybody? Because the problem is that we're 8 billion humans in this earth, and not everybody is going, very few of them are going to get lung cancer. So we cannot be exposed into radiation therapy, especially young people around 50 for 40 years, you know, or 30 years, you want to live 80. That's why the screening is for a high risk group. As Dr. Stellamari said, above 55, they have been smoking for 30 years, 1 pack a day. So these patients are going to qualify for high risk and benefit from the screening. Maybe other people will benefit, maybe, but we don't know that yet. Yeah. So now that we are going to our last presentation has is a pre-recorded video, but we cannot display the video now for technical issues. So what we're going to do is we're going to email all the attendees after the webinar. It's a very important discussion about patient advocacy, access to quality care, pharmacy benefit managers, and support that you can get in our Flasco patient portal. In Flasco, we have a patient portal that we have a lot of information about all of our industry partners and all of many issues that we have discussed today. You can email to info@flasco.org if you want to participate also in our patient advocacy. I only want to give thanks to all of our panelists to present this evening for all of this important information. Also want to give thanks to our sponsors at Genentech and Foundation Medicine. And as a reminder, all the handouts mentioned in this webinar can be found in the handout section in your right side. You can download them now. We have 4 handouts there that are free for download. And also this webinar was recorded. If you miss anything, you want to hear again, so some part will be available in our Flasco website soon. So thank you very much for joining tonight. In the name of Flasco, we wish everybody a good night.
Thank you. Good night. Bye.
Good night.
Good night.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education, you can advocate for family members, you can help assist with certain components of their care, and all that is advocating, and there are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' health care, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways, and I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Flasco, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money. We're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, "You don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks." She said, "You did a great job with that." The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the U.S. government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, Some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers, because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients, or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on. But also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about, months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. It's like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to their medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of the thing. That's how they affect the pricing end of the thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the #1 line of therapy, a medication that its #1 side effect is that it can impact the kidneys, okay? Well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that #1, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't #1 on their formulary list. So we have several examples of where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is frontline and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year. and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more for pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers. But we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.